See a lot of people joining in now. Excellent. So we'll let that stabilize a little bit and then we'll get going here. So welcome to the Provincial Health Leadership Program keynote address, hosted by the George and Fahey Center for Healthcare Innovation. My name is Dr. Peter Nickerson. I'm the Dean of the Rady Faculty of Health Sciences at the University of Manitoba. And I'm pleased to and delighted to have Dr. Verna Yiu here joining us this evening to discuss the Canadian healthcare system. And how we got here won't get us there. We want to start by acknowledging that the Center for Healthcare Innovation is located on the ancestral and current day lands and waters of the Anishinaabe, Cree, Ojibwe, Dakota, and Desaline peoples, and on the national homeland of the Red River Métis. In northern Manitoba, we acknowledge the ancestral lands of the Inuit and gratefully acknowledge that our water is sourced from Shoal Lake 40 First Nation. We respect the treaties that were made on these lands. We acknowledge the harms and mistakes of the past and present. We dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. This evening, we're going to hear from Dr. Yiu and explore how the pandemic has reshaped health systems, the role of resilience, key steps in moving forward. Dr. Yiu has spent more than 2 decades in leadership roles and is currently serving as the Provost and Vice President Academic at the University of Alberta, as well as a Professor of Pediatrics in the Division of Pediatric Nephrology at the university, while continuing to work on the front lines, providing care to young patients and their families. Dr. Yiu led the country's largest province-wide healthcare system that protects and improves the quality of life for 4.4 million Albertans for over 6 years. And Dr. Yiu's 6-year tenure as President and CEO of Alberta Health Services, she was named one of Canada's top 100 employers for 4 consecutive years, along with employer awards. Other accomplishments during her tenure include optimizing provincial care integration, which earned Alberta Health Services recognition as a top 5 most integrated systems globally by the International Society of Integrated Care, reducing growth expenditures by over 50% while maintaining quality and safety, and leading the implementation of Connect Care, Alberta's first province-wide clinical information system with government support to transform care delivery. Dr. Yiu is one of Canada's most respected healthcare leaders, and we welcome her warmly this evening. Lastly, before we begin, we'd like to kindly inform you that auto transcription is enabled for this virtual event. You can toggle it on or off at any time by selecting the captions button on the bottom of your screen. Additionally, we'd like to introduce Victoria Vasilkiv, and the coordinator of the Provincial Health Leadership Program. Victoria plays a key role in organizing and supporting this event and will be leading the question period at the end. Please feel free to submit your questions or comments using the Q&A feature below, and Victoria will guide us through the submissions during the question period at the end. Thank you for your cooperation, and now, welcome Dr. Yiu.
Great, thanks very much, Peter, and it's a delight to be here. My title of the slide actually comes from Marshall Goldsmith's books, which is entitled What Got You Here Won't Get You There. And I actually feel that for Canadian healthcare, we have to get to our next level of achievement, which I think still has a ways to go. Moving on to the next slide, I also like to acknowledge that we're located here on the territory home and a traditional meeting place for First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence, histories, languages, and cultures continues to enrich our vibrant community. I also want to wish to honor the elders, knowledge keepers, and traditionalists who have gone before us and those who continue to walk with us today. The next slide goes over the objectives. Peter already sort of went over what I'm hoping to achieve by the end of the session. And so just going back to COVID, I just want to, in the next slide, just, talk about, and we've all, I think, remember not so fondly our own experience with COVID and the pandemic. But, by the end of 2023, it was estimated to have caused in excess of 18 to 33 million deaths worldwide. And we know that COVID is going to be with us. And what we'd also know is that, there are multiple sources who suggest that there may be a similar scale pandemic possible in the coming decades. So, the Spanish flu was about 100 years ago. I think we'd be lucky if it was 100 years to another pandemic. And going to the next slide, what it really has shown is that, Canadian healthcare is challenged. And the pandemic really highlighted for us numerous things. including the fact that, in general, our healthcare system is very fragmented, not only in terms of the care, but the transitions in our communications, our lack of data. There are gaps that resulted in poor outcomes. There was challenges around publicly funded institutions versus privately funded institutions, the coming into question around sustainability of our system, obviously the ability to catch up on the backlog, capacity in the system, how public health works and its role, and obviously the biggest challenge right now is our workforce shortage and inability to really retain healthcare workers. Healthcare inequities has obviously been further entrenched, and we've been aware of health inequities for decades, right? Since the 2001 IOM report. But COVID really entrenched the pre-existing inequities in communities that are impoverished, and our migrants, our refugees, and ethnic groups and Indigenous communities, and also inequities for those with chronic illnesses, mental health, seniors, again, those with marginalized populations. And we saw that with poor outcomes, higher morbidity in those types of populations. In addition to that, the politicization of healthcare was really quite prominent. There was an unprecedented level of politicization of medical care. We've heard how elected officials declared COVID to be a hoax, ridiculed mitigation effects such as mask wearing, promoted unproven therapies such as the administration of hydroxychloroquine, to list one of them, whether to receive a vaccine or not. And it really became a matter of political identity. And so misinformation about COVID-19 was so widely circulated. I think we all know how it resulted really in partisan differences around social distancing. There was so much interest in unproven or disproven therapies, hesitancy around vaccination, and it really resulted in rates of increased hospitalizations and death. And really reports in the lay press highlighted the mistreatment of nurses, physicians, by patients and family members that were influenced by politically motivated misinformation. And then we get the workload and the exhaustion amongst physicians and other professionals. And obviously all of that has been really well chronicled. When it comes to work overload and exhaustion, I mean, we're all seeing that, and we're actually even seeing that today. We know that some publications have shown that physicians, for example, caring for patients with COVID-19, we're working with insufficient PPE. They experience negative economic impact due to the pandemic, and personally having COVID-19 infections with higher rates of burnout compared to physicians without these experiences. Less is really known about the negative work experience related to the politicization of healthcare triggered by the pandemic and the impact of caring for patients with COVID who chose not to be vaccinated, particularly in the setting of long work hours, workforce shortages, and really reduced access to much needed leave really added to the fatigue. And so when we look at, again, the impact on physicians in particular, most physicians experienced intrusion of politics into medical care during the pandemic. These were associated with professionally conflicting emotions, including less compassion and empathy. There was greater frustrations and resentment. And it led to really moral distress, and compromised integrity were also associated with less professional fulfillment and greater occupational burnout. And this was shown in this study that I quoted here, which was in a sample of about 2,800 physicians that was in emergency medicine, critical care, or non-critical care hospital medicine, and really was reported that about 92% of physicians experience stress related to the politicization of medical care. Just moving on to the next slide. I'm really proud of the work that we did in Alberta and Alberta Health Services, the incredible, awesome things that they had to deal with in the pandemic. And I just list a few of them. We were very grateful that we didn't have to transfer any patients out of province. You can see that we doubled our ICU capacity. At one point, we were planning for ICU capacity of about almost even up to about 1,000 patients, and over about 900 ventilated patients. We were pretty confident we could provide care to. You can see our COVID testing. We started off with testing, I think the first weekend when COVID first appeared, we were testing about 30 a day, and at its peak, we were testing about 23,000 per day. We increased our contact tracers from 50 to over 3,000. HealthLink is our phone line. You can see that we increased our calls by about 157%. Everybody in the country immediately switched to virtual care. We went from about 60,000 visits per year to 60,000 visits per month. We set up 2 virtual hospitals. We were able to increase our capacity in 21-22 to over 600 patients who otherwise would have required hospitalization. So we were very, very pleased with that progress. ASI stands for our surgical initiative. And in fact, if it wasn't for the Delta wave, we actually were caught up on our backlog of surgeries before wave 4. And then we were the first in development of an online assessment tool for COVID. We were first around developing an online vaccine booking tool. We developed a modeling tool for PPE that helped us predict about 2 weeks, 3 weeks out how much PPE we exactly needed so that we were always ahead in terms of ordering and shipping. And then we developed an early warning system tool that allowed us to predict about 2 to 3 weeks out how much bed capacity we needed for both inpatients and ICU patients. Just to give you an example on the next slide around PPE usage, you can see here the incredible number of things that we are using in terms of percentage over baseline. And when we think about, and I'll just use masks as an example, for procedural masks in any typical day in the province of Alberta, we're using about 44,000 masks in a day, and we've got good data provincially that we were able to assess that. At the peak of COVID, we're utilizing 750,000 masks a day. Having never gone through a pandemic, how do you even predict those numbers? And so actually having that type of data and developing a modeling tool that allowed us to predict how much we had to order a month in advance really allowed us to keep up. And in fact, we're able to share millions of masks with both Ontario and Quebec as a consequence of that. When we think about COVID recovery and resilience, we're obviously in a much different place than we were in the winter of 2020. But when we think about disaster recovery, it is well researched in sort of how we recover. And it is really clear that the recovery for COVID is actually not linear. And when it comes to individual people, they're going to experience a wide range of emotional responses at different phases of a disaster. And really, recovery should really focus on understanding the individuals, the communities, what they need to cope with in terms of impacts of a disaster. And recovery is going to be long. And when we're thinking about a long haul, we have to think in timeframes of years. And so if you think about the time that we've really been out from 2022 to now, it's only been about 2.5 years, but really we have to think about recovery even in excess of that. So just coming back to a little bit about resilience, and so skipping topics a little bit, but I just want to share with you a bit about my own experience as a healthcare leader. And my career path has generally been pretty smooth. I was fortunate enough to work in areas that I was passionate in and led me in paths that I never expected I'd end up because really at the end of the day, I just want to be a community pediatrician. But this is a really good slide that came from Jim Conway from many years ago. But when we come out as healthcare professionals, whether we're physicians or not, many of us don't actually think about leadership early on. And you can see here when we first come out into practice, our technical skills are really impressive. And over time, as you actually become further along in terms of leadership, you can see that things that are really going to advance are really going to be your personal leadership skills. And it's really important that we acknowledge that. And I look at our students and think they really have a right, because many of our students and student groups really are focusing on leadership at their ages when they're in their 20s. When I was going through all of this, I really didn't start thinking about leadership until I was well in my 30s, and really also in my 40s. So I think for many of us we have to think about it at a much earlier time. And so when I think about resilience, this is going to the next slide. This is from Dean Becker, who's president and CEO of Adaptive Learning Systems, which is a company in Pennsylvania that develops and delivers programs on resilience training. And I really liked his comments, which is that, resilience, and when we think about it, is something that you kind of realize after the fact. I've never really thought of myself as resilient until some of the things that I actually had to go through in my career. It's really determines who's going to succeed and who fails. And it's not a judgment call about resilience. It's not an ethically good or bad, aspect. It's really just a skill or a capacity to be robust under stress or change. The really good thing about resiliency is that it actually improves with age, is one of the few things that improves with age. And when we think about getting to sort of our middle parts of our life, middle age, really our ability to regulate emotions, perspectives gained from life experiences, concerns for future generations. It really does give older individuals an advantage over youth when it comes to developing resilience. And really, when we think about leadership competencies, it really is seen in that light. When we move to the next slide, it just shows you that when we think about resilience, we tend to think it's just one aspect of it. But in essence, there are actually four sort of dimensions, right? There's the physical dimension. That's really important for all of us. There's the mental aspect, which is around outlook, perspective, self-belief, self-awareness. It's that emotional component where you really have to be focused, be able to control your emotions. And then the spiritual piece, which is about the empathy, the reaching out. So there are different dimensions of resilience that we always need to be cognizant about. The next slide is actually a synopsis of one of probably the best articles I've read on resilience, and it's written by Diane Kutu, who's in the past actually was, she was a writer for Harvard Business Review, senior editor and writer for about 11 years. She worked as a foreign correspondent for Time Magazine and later the Wall Street Journal. And she studied English literature at Yale and politics and philosophy at Oxford. And this article really talks about three components or three characteristics of resilience, of which you need to have all three of them. And I'm going to go through a little bit more detail about what each of them entails. So in the next slide, talking about facing down reality, there are some which is really kind of interesting in that they believe that optimism is the key to resilience. And in fact, when we look at some of the origins of where resiliency training comes from, and it was out of University of Pennsylvania, their resiliency program that they created was basically teaching, it was primarily in education to start, and basically they taught teachers techniques about how to be optimistic. But optimism alone can be detrimental. And in the book that was written by Jim Collins, From Good to Great, which is really one of the classic books, when he interviewed Jim Stockdale, who was held prisoner by the Viet Cong for 8 years, and when they asked him, who didn't make it out of the camps, and Stockdale replied that it was the optimists, that they were the ones that were unable to continue. They were the ones who said that we're going to be out by Christmas, or Christmas came and then it was by Easter, and then it was the 4th of July, and then by Thanksgiving, and then it was Christmas again. And he described it that they died of broken hearts. So facing down to reality is really about preparing ourselves to act in ways that allows us to endure and survive extraordinary hardship. And we have to train ourselves how to survive before the fact. The second component of resiliency skills is about the search for meaning. And so resilient people develop constructs about their suffering to create some sort of meaning for themselves and others. And Viktor Frankl was an interesting individual. He was an Auschwitz survivor. He was also a psychiatrist. And he developed some methodologies around being humanist in the world of psychiatry. But he was also an Auschwitz prisoner. And what had happened to him, there was kind of an epiphany moment for him when at one point he was trading a cigarette for a bowl of soup. And it was at that point that he decided that he had to have more meaning in his life, and then pictured himself as a psychiatrist actually speaking to an audience and educating others about what Auschwitz was about. And so for him, finding the meaning in life at that moment, when the situation seemed absolutely hopeless, was when it totally changed how he was than really surviving and gave them purpose. And then the third building block for resilience, the ability to make do with whatever you have at hand. So I'm sure that you've had friends and colleagues that you've gone through sort of turbulent times and yet have responded in very different ways. And when you watch the ones who've succeeded and the ones who have not, the resilient leaders or individuals really try to imagine possibilities where others are confounded by. And so is that really the ability to bounce back, being adaptable, flexible, really having that inner sense of direction. And humor is a very important part about resilience. And so the next slide really just gives you these kind of 8 steps to become more resilient, about accepting change, becoming a continuous learner, taking charge, finding your sense of purpose, paying attention to your self-identity from your identity apart from your job, cultivating relationships, reflecting, and then skill shift, question and even change your definition of yourself or career. I just want to quickly talk about organizational resilience because that's a little bit different. A resilient organization is one that's really able to achieve its objectives even in the face of adversity. And so really the pandemic was the ultimate test to any healthcare system, right? And so it really is about being well prepared, not really, and really survives over the long term and passing the test of time. And so in the next slide, just want to share with you an example of a very resilient organization, which is Morgan Stanley. So prior to 9/11, Morgan Stanley, which as you know is a very famous investment banker, was the largest tenant in the World Trade Center with about 2,700 employees on 22 floors. And in 1993, there was a car bomb attack that occurred in the World Trade Center. And Morgan Stanley at that point had the insight and the grim realization that this could happen again, but on a larger scale. So they hired a man named Rick Rescorla, who's the one with the bullhorn there. And then he joined Morgan Stanley. And shortly after 1993, he started practice drills every 3 months to prepare staff for potential terrorist attack. And so when 9/11 happened, Rescorla went back to the Twin Towers, pulled out his bullhorn and started the drills. And out of 2,700 employees, only 7 did not make it out. And in fact, it was very sad to say that, in fact, Rescorla was one of them. So Morgan Stanley had the insight to invest in contingency planning. They stare down at reality and really prepare themselves to act in ways that allow them to endure and survive extraordinary hardships. Next slide, I'm just going to shift to now, what is a path to becoming a systems leader? Because I think at the end of the day, when we think about leadership, what is it about some of us who wants to be a systems leader? And it really is about shifting the conditions through which others can learn collectively to make progress against it. And so system leaders have similar impacts, right? They have a profound commitment to the health of the whole, and that radiates to sort of nurtures hopefully similar commitment in others, the ability to see reality through the eyes of people who are very different from themselves and encourage others to be as open, ability to build relationships based on deep learning, and are so convinced that something can be done that they don't really want to wait for a fully developed plan, thereby freeing others to really step ahead and learn by doing. And one of the biggest contributions really comes to their strength of ignorance, actually. It gives them permission to ask obvious questions, embody an openness and commitment to their own ongoing learning and growth. So moving forward then from sort of our resilience, systems leadership, let's talk about the system itself and how we're going to rebuild our system. I'm going to speak really around 4 aspects. One is around workforce, paradigm shift, accelerate digital change, and then plans for future public health emergencies. Moving to the next slide, if we think about the workforce, when the total number of job vacancies in Canada for healthcare workers is more than 900,000. It would not surprise me in 2025 that it's actually more than 1 million. And so when we think about the occupations that have the most vacancies, LPNs, RNs, psychiatric nurses, and just to recognize that the labor demand was actually an issue pre-COVID. So COVID definitely exacerbated the workforce demand. And we do know that the retention and the burnout has been astronomical and continues to this day. And if you look at sort of the UN high-level commission on health, employment, and economic growth, they actually have shown that the prediction is that by 2030, you're going to need an additional 9 million nurses and midwives. So the shortage is not specific only to Canada. It is actually a global issue. So when we think about rebuilding our workforce, it is actually focused on a number of different things. It really is about looking at talent supply, right? So focus on optimizing both internal supply as well as external supply. So internal through career pathways, continuing education, post-secondary program expansion. In AHS at the peak of the pandemic, we actually started hiring fourth-year nursing students as employees so that once they graduated, then they knew that they actually had a job in hand, and really resulted in actually increased recruitment. You've got to be able to incentivize not just the attraction, but also the retention, especially for critical areas. We know where the shortages are, sort of especially in the high stress areas like ICU, emergencies, emergency rooms, and so on and so forth. And then, external supply through obviously the national and international nursing campaigns. We know they target not just the US market, but they're also targeting globally. There's some ethical challenges with that. But at the end of the day, I think it's this global shortage. And what we're trying to do is trying to do our best to, supply our talent. Retention is a much less costly method to retain than to have to continually recruit. And so retention strategies has to include not just pay offers and compensation, but opportunities for flexible work hours and very clear career pathways. So for example, in AHS, EMS or paramedics are actually embedded in the healthcare system. We know what the burnout rate is for paramedics. And so what do? We actually offer them different career pathways. So for example, we had paramedics who worked in home care. We had paramedics who worked within the emergency room settings. And so it's very important to really provide that. And continuing education, specialized training is also very important. Optimization includes scope of practice, make sure that you've got, optimal mix in all settings, improving the coordination of the different pools, the casual pools, permanent pools, and really anticipate workforce needs through modeling and forecasting. And we know that there's now a national pan-Canadian organization called Health Workforce Canada, which I want to just declare I am a board member of. But the intention of Health Workforce Canada is to provide not only a dashboard for health workforce, but also to share best practices and how to optimize our ability to recruit and retain. And wellness obviously is very critical to support and provide good patient care. And they do need to be given the time, the space, the resources to recover. I think it was one of the major challenges in COVID was that we really didn't have any ability to give people time off. And then obviously the support programs. And all of these are really important to really make sure that we create a culture of compassion, inclusion, and collaboration. So moving on to the next slide, the other aspect of rebuilding, so it would be the next slide after this. Next slide after this. Oh no, I think you're going before. You mean go forward instead of backwards? Perfect. It really is around what we need to do as a health system. Back in 2019 in Alberta Health Services, as we looked into the future of healthcare, it was clear we need a paradigm shift. And it really is about paradigm shift of really moving us away from all of these very traditional models. So, we're very acute care centric. So moving from an illness focus to a wellness focus, we are, single provider care into a team-based care model, is a very physician medicine centric to now a patient family focused. And as I mentioned, we're very acute care, hospital based, and we really need to think about community-based care and community-centric care. And so really it is important about, advancing the transformation of healthcare systems and to sort of move away from that. Because as long as we keep the focus on those entities that's listed here in those black boxes, there will be no solutions to how we look at healthcare. So moving on to the next slide, it really is about a paradigm shift. And so it really is about putting patients and families in the driver's seat. One of the really great things that we have now finally rolled out in this completeness is a provincial electronic medical record system. And you as a patient, family member, now have access on your smartphone to your data. No matter where you live in the province, you've got access to your diagnostic data, to your lab data. You can text, communicate with your care team. It'll provide you with reminders with anything that you need to do. But having well-informed patients and families who are in the center of the care team is actually paramount to actually shifting the focus to wellness and what they can do beyond sort of the acute care treatments that we give to patients. It really is about changing, moving away from old practices, reducing low-value care. Low-value care is pervasive, accounts for about 10 to 20% of healthcare spending. So think about treating viral infections with antibiotics, imaging for non-specific low back pain. We should be spending this funding on providing high-value care for those who need it the most, building stronger prevention, public health, and pandemic preparedness capabilities, addressing health disparities and systems inequalities that underlie them. Moving on to the next slide. And then, obviously we need to advance technology. And with COVID and with the advances, we saw the gaps. We saw the gaps in data and information. And the one patient, one record was the vision that we had when we actually went into government to ask them to support us on this provincial EMR rollout. And with COVID, there was digital transformation, right? I mean, there was rapid expansion of virtual care. There was hospital home programs, remote monitoring. We did expansion of community paramedicine, to list a few, and then creation of predictive analytics tools that I kind of talked about. And so, digital technologies is absolutely there, but we also need to be cautious to recognize that there is a potential risk of widening of health inequities and inequalities. Moving on to the next slide. So really, it is about moving from the quadruple aim for health systems to now the quintuple aim. And I would say that that's probably now the framework that most systems are using. Health inequity is in fact actually embedded in the quadruple aim. It really is about improving patient outcomes. But with COVID, the health inequities were highlighted in ways that we knew were always there, but this time with concentrated, devastating outcomes. And so really it has to be explicit. It means that no one is denied the possibility to have optimal health and well-being, even if belonging to a group that has been economically or socially disadvantaged. And as I said, we know that there's clear evidence that race, ethnicities, sexual orientation, gender identity, socioeconomic status, functional limitations, and other characteristics will contribute to disparities in the implementation of health interventions if inequities are not addressed upfront. Patients and community-centric care systems leaders have to shift the conditions through which others can learn collectively to make progress. And really, it is about, as I said, putting patient in the center of the healthcare journey, providing transparency of data so that patients can be fully informed. That they're going to come in to see you already having been to Dr. Google. But one of my biggest, I would say, pet peeves in our current environment is that we don't have enough health literacy for the public, so that when they are trying to interpret Dr. Google, that they can actually have some baseline knowledge about health and healthcare that actually helps them make decisions. Really, it's about community-centric care. A lot of times, at least in Alberta, and I don't know if this is comparable in Manitoba, but in Alberta, we actually opened a lot of hospitals in small communities without good reasons, in the 70s and 80s. And so we got a myriad, we've got like 99 plus hospitals in Alberta and in communities where it really doesn't make sense. And what happens is that those hospitals become economic engines. It becomes the identity of the community, and the communities can't really think of anything else other than having the hospitals there. And that's a challenge because maybe the community doesn't need to have a hospital. And so really, we've been doing healthcare planning backwards. We should not be identifying what the solution is before we identify what the problem is. And so we've really tried to advocate very strongly when I was president and CEO of really doing community broad engagement about what communities need. Maybe it's primary care they need more so than hospitals. And really, using demographics, information about health, morbidity, mortality data, and really use that data to talk to communities about what is it that they need, what do we need to invest in for them to be a healthy community. And I think that's been lost. It's a very difficult discussion politically, but really from a context of planning for healthcare, that's where we need to be. And then obviously being innovative and creative about what our system looks like. And I think across the country, we were so innovative and creative in healthcare when we had to do that. So moving into the next slide, it really is about thinking outside the box. Situations which suffer from polarization and inertia become more open, and what was perceived as intractable problems can be seen as opportunities. So short-term reactive problem solving becomes more balanced with long-term value creation. And then organizational self-interest becomes recontextualized as people discover that their organization's success depends on creating well-being within the larger systems of which they are a part. And so my last slide is really about the fact that, we are stewards of our healthcare system. We need to be able to recommit to our publicly funded healthcare system. Something that I'm very proud of is why I came back after training in the US to Canada. I couldn't espouse the public health system enough when I was down in the States. But it's been over 50 years since Medicare was established in Canada, and we need to recommit ourselves for another 50. But we can only do so if there is change, and change for the right reasons with the right outcomes. And who best to know that but healthcare leaders in our healthcare system. So thank you very much, and I'd be happy to answer any questions.
Thank you so much, Dr. Yiu. So you are all welcome to submit questions using the Q&A feature at the bottom of the screen. We have received some already, so I will start there. So firstly, in your bio was mentioned that the Alberta Health Services was noted as a top employer. And what, in your opinion, has made that a reality that health systems should continue to support?
Yeah, so let me tell you that top employer award is not easy to get. When we actually launched a people strategy, we actually had the quadruple aim as our framework. And so it started off with a patient first strategy, right? Go figure, you need a patient first strategy to show the importance of patients and families to a healthcare system. But we realized very shortly, and at that time, IHI in the US was really promoting the triple aim. And what was missing for us in the triple aim was the people part, right? And so with that, and in fact, we actually had the head of IHI visit Edmonton at that point, and I was saying to him that, really you should be moving on to the quadruple aim. There's no reason why, and people has to be part of that triad to, making it a quadruple framework. And so when we then embarked on the importance of people, right? You can't ask people to support patients and families if you don't support the people. Healthcare systems are about people. And so we created a very robust people strategy with an action plan with 3-year deliverables. And one of our 3-year deliverables, actually for the 3rd year, was to be a top employer of Canada, a top 100 employer of Canada. And we actually got it in our first crack. And so grateful to the teams and to the people. And part of it was really around things that were really important was around the supports for our employees, right? So whether it be in mental health, whether it be supports in their workplace, whether it be development training so that they can actually get development, education. One was a very critical offices that we opened was really on diversity. And I know EDI is not necessarily a nice acronym these days, but EDI was a very important aspect for us. And we did a lot of workshops on training on conscious biases, making sure that we were ensuring access was available to everybody, and then you hire based on merit, right? So it was really around sort of those programs that actually helped to support the people. And, the Top 100 Employer Award there's about 10,000 organizations that actually submit applications to be in the top 100. And so, and then alongside with being top 100, we got Top Diversity Award. We got the top Employer Award for young people. And then we were obviously in Alberta, the top 70 employers award. So it's we were very proud of it, and it took a lot of effort.
It definitely shows, of course. Our next question is, so you spoke a bit about the health-related paradigms that need to shift. But in your opinion, what should happen at the government level to allow for further fundamental changes in healthcare?
Yeah, so we're kind of in Alberta, a bit of a depressing time for healthcare. And I actually really think that right now for governments, I respect the democratic process, and that elected officials are elected, that we've got a democracy, and each governments have their mandates, and that's fine. That's what Canadians have voted for, and so I understand that. But I think one of the challenges with healthcare is that healthcare systems and delivering on what we would like for healthcare outcomes for Canadians can work. We've shown that. We've shown that in Alberta, in the AHS, the progress we made in our 6 years, having a stable system with a 3-year, we finally got government to agree on a 3-year health and business plan or a 3-year strategy. Prior to that, it was annual. How do you get anything done? Right? So I think part of it is really understanding that, yes, government has mandates, but please let the healthcare professionals deal with the healthcare system because they know it best. Right? Would you ever ask a non-finance person to run a bank? No, you would not. So why would you do that in healthcare systems when your knowledge of the system is so critical? It is such a complex system. And so really, the politicization of healthcare has been really problematic, I would say, with the pandemic. And it's just kept them it's set up really bad habits that are continuing to this day, where they continue to sort of dive in and want to do this and want to do this. Give us time. In Alberta, we were able to bend the cost curve without laying a single person off. We actually reduced, at one point, we were the lowest in growth. In fact, we were sort of almost static, and that was through some incredible work that we did. And we were about to, make some inroads around some of our, clinical outcomes. So give us time to do it. Give us the policies that you want to mandate, but then let us do it. Let the professionals do it. Healthcare systems are not free markets. Applying free market strategies to healthcare is a problem in Canada because there are monopolies. And so free market principles don't work. And so, let the professionals do it, give us our deliverables so that we're accountable, but then trust us to do the work. I think that's why, in all honesty, we were successful, is because we had a government at the time, and I'm actually apolitical, believe it or not, but we had a government at a time where we were disciplined on how the minister and the deputy worked with the board chair and the president CEO. So it's really hard to do. Really hard to do. And if I was to give advice to governments, I would say to them, integrate healthcare, please. Like, don't disintegrate. Integrate healthcare and invest in primary care and preventative care.
Well, thank you. And building off a bit in the topic of government, how were you able to convince the government of Alberta that investment in innovation and technology for healthcare delivery is an essential step for moving healthcare forward?
It's not easy. And I can share with you at one point, we have to change our language. So just, you have to change your language a bit sometimes and use language that people can that resonates with people. So, for Alberta Health Services, we had a research budget. It was primarily spent on our strategic clinical networks that allowed us to move out best practices into Alberta. But there were research arms of that, and we worked very closely, obviously, with our big U15 universities in the province. But I can tell you that every time we would get questioned about what is this research budget, you shouldn't have any money that goes into research. Well, then we have to shift. And we said, okay, we're not going to call it research anymore. This is about innovations, right? And Peter's nodding because you got to change your language sometimes. And so, we just gave them examples, like how do you innovate anything in the healthcare system if you actually don't have some skin in the game? And so strategic clinical networks is a really good example. These are multidisciplinary grassroots teams that are systems based. So it was, cardiovascular, SCN, it was neuromuscular, SCN. And so, they were systems based strategic clinical networks. And we invested about $20 million in a $16 billion budget. $20 million is not a lot, but what it did was that it created a bit of a framework that allowed us to actually look at sort of where's the biggest bang for the buck? Where can we make the most difference clinically across the province? Standardized practice so there's reduced variation, which results in poorer outcomes. Invest at sort of top projects. So one of the projects, as an example, was enhancing recovery after surgery. We started with, sort of very small hospitals. This is about a protocolized approach to surgery. So surgeries preoperatively follow a certain protocol around eating. They get fed right away. This is like colorectal surgery that we started with. They get, oral intake within 24 hours and then follow, sort of a regimen after that. And you know what they showed? I mean, we actually reduced the length of stay for all of those patients, and we saved days. This is how we kept up with our capacity. So by investing upfront, maybe $2 million in something like that, we ended up saving more money because we actually created capacity that allowed us for them to, take in more patients. So I think this is where you have to give them some examples of, things that they can relate to and what the cost benefit analysis is. We never invest on anything without a return on investment conversation, and everything was a business case. What was the return on investment at what time? And everyone was reevaluated every year. So we were pretty disciplined about what we invested in. And so.
And speaking of business, so this question provides a little bit of context before the question. So quoting here, community care in Canada is largely based on small businesses and fee-for-service clinics who are under-supported right now. One major issue is the high staff turnover because they can't compete with health authority salaries and pensions. How do you think the health system can support and work in synchrony with small businesses to better support how they function, the families they serve, and the community care?
So I may be speaking heresy here, but that is the big elephant in the room, is that when Medicare was set up, I think one of the challenges, it took actually about, I think, Peter, it took about 10 years to actually get the concept to reality. And part of the time lag was actually getting the physicians on board. And so physicians wanted their autonomy, they wanted their offices, but practices were very different then. They're doing house calls, it's a very different world. There were there was much fewer treatments. And so, really, when we think about community care, it's one of the major issues, I would say, that when AHS was created back in 2009-10, one of the big missed opportunities was actually embedding primary care into the system so that everybody had an opportunity to actually be part of that. And in fact, Saskatchewan Health Authority listened to us when they were planning to amalgamize and provincialize. We said that to them. We said, you know, if we had to do it over again, we would embed primary care so that primary care was no longer seen as a distinct entity. And in fact, in Saskatchewan, when COVID hit, they were very efficient at providing resources to the primary care community in terms of different, more compensation for what they needed. There was much less stress for the primary care docs in Saskatchewan as compared to, I think, every other province, because they were actually embedded within the system. And I think we need to move away from fee for service. You know, our current generation, right, Peter, when you look at your medical students graduating to residencies, they don't want to work, they don't want to own an office anymore. They want to be paid a salary. They should be on some sort of, I don't know, blended cap or some sort of comp model that actually shows some accountability on what they need to deliver. But the system also has to deliver to them and support them to be able to do the work. And so really, we do need to move away from fee for service. And I think it's going to happen. The next generation is telling us that they don't want to do what, you know, we did decades ago. And so it has to fundamentally change.
Well, and our next question also gives a little bit of context. So addressing the notion of continuing practices, simply because it has always been done that way, such as situating hospitals in traditional locations, for examples. So how do we navigate and manage community or team expectations when implementing these changes that challenge these sort of norms that involve further community engagement to fix?
Yeah, that's a really hard question because everybody wants the shiny building. Everybody wants their hospital. And that's why I'm saying that we need to educate Canadians in improving their health literacy, period. Like that. And I think it's not even the adults, it's actually the children. If we can start building in health literacy and education in K to 12, that will influence their parents, and it would have a much better effect. Because until we understand, so I'll give you a really good example. We've got a little town, it's not little, but we've got a town between Calgary and Edmonton who wants a cardiac cath lab. And but they've got a donor, right? And you know, the community was up on arms about wanting this cath lab. And we said, well, you don't even have rehab. What do you mean you want a cardiac cath lab? They don't even have any cardiologists at that time who could actually do cardiac cath. And what we showed is that if you actually invested in primary care and primary care programs, you would actually affect the mortality and save 28 people versus 1 with cardiac cath lab. Did that actually help the conversation? No, it did not. But what I'm saying is that if we were able to educate the community to say, listen, for a fraction of the cost, if you invested in this first, that you could help this many people and really have that conversation versus the shiny new toy, which no system is able to sustain. And so I think it's that community conversation that we have to have as a public, that government has to have with the public. And we just have never, ever gone there in any meaningful way. So I would challenge every province to do that. But, you know, by the time governments get in, they got 2 years to do anything they want, and that's it. And nobody's around long enough to really have those conversations. And, you know, why do it? Like, it's not, but it's really important for health systems. And we were starting to do some of that in Alberta. And it was really powerful conversations we were having with the community. You know, we just never got any supports to continue.
Verna, I'd like to ask a question about scopes of practice. I think you've been pretty good in Alberta about getting expanded scope of practice for things like pharmacy and other areas. How did you achieve that? and it's because I think we are lagging behind in that in Manitoba. And how does that conversation go so that people don't feel threatened in their own practices? I think that is one of the key questions. And how do you overcome that resistance?
Yeah, so I mean, the pharmacists are a really good example of that. And, the Alberta Medical Association was very publicly against the pharmacists in expanding their scopes of practice. And it didn't matter, government didn't listen and they just did it anyway. I think that's what you need. You got to just have that backbone to say, okay, if we're going to do it, we're going to do it. These are the premises on which it's going to happen, and so on and so forth. I would have to say that the pharmacy experience saved our bacon when it came to immunizations. If not for the pharmacists taking over the immunizations, because we actually went to the family physicians to ask if they were willing to do the routine or the COVID vaccinations, and they weren't in positions to do that. They didn't have the bandwidth, they didn't have the facilities to do it. The pharmacies, they were at one point, we were doing about 25,000 a day. The pharmacists would pick up the same amount, if not higher. So we're, like 60, 70,000 a day. And so, I think the resistance will always be there, Peter, no matter what. And you just got to have the backbone to do it. And over time, it'll just die down, because then the people realize this is not as much of a threat as you think it is, right? Because
Yeah, exactly. And then the other question is, you mentioned it in your talk about team-based care. Well, what's that looking like in Alberta? Because
Yeah.
I think, we talk about it, but how do we actually achieve that in a way that is truly team-based? And it sort of goes to the scope of practice a bit, but are we actually committed to team-based care?
Yeah. So there's strategies and actual practices that goes into building teams, right? And so way back yonder, probably about 10, 15 years ago, one of our general internists in Edmonton created a project called Care Transformation, and she published a work. And Care Transformation was really about building a team. That in essence was what it was. They actually had very regimented protocols, so they would have rounds at certain times of the day. There was role clarity about who was doing what. The physicians would show up at such and such a time. Patients would be engaged in it. And through that work, she was really able to show that you could actually reduce your ALOS-ELOS down to less than 1 on a consistent basis, and then obviously resulted in, savings longer term. We actually translated that care transformation program into something that we called COACT, so COACT. And so it is sort of a methodology around how units work together. And we started off in medicine units, again, show the same result. It really is about talking, working together, building that trust, accountabilities, responsibilities, role clarity was really important as part of that. Physicians were part of it. So it was all in. And it was a method of team building, to be honest. Surgery wanted in on it because they could see the benefit. So we expanded to surgery. And what was really important for us was to expand it to seniors care, right? Long-term care facilities don't have that either. And so we were really excited. We try to expand it down in the south part of Alberta, but we're actually able to show really good results. We had to put a team together that sort of helped oversee the provincial rollout of COACT. So there has to be some purposeful commitment from the health system to invest and you know what, you get benefits. So, reduced length of stay, reduced readmission rates, better patient engagement, better employee engagement in all of those units. And like, why would you not do it? And reduce adverse events, right? Improve safety.
Have you tried this within rural communities?
Yeah, absolutely. Yeah. We had it in smaller, it wasn't just in Edmonton. It started in Edmonton, but then we expanded it to Calgary, expanded it to other hospitals in the province. Absolutely. Fort McMurray, Red Deer, yeah, Grand Prairie.
Excellent.
It works.
All right, thanks, Peter, for your questions as well. We are going to also shift the paradigm a little bit here in the presentation and Q&A to more about your leadership journey. So what was the most challenging aspect of transitioning from a clinician to a healthcare leader?
I never stopped clinical practice. The only time I couldn't do any clinical practice was the 2 years of COVID. And I just, oh my God, it was just, Peter asked me, what's an easier job, provost job or CEO job? I said, oh my God, provost job by far. So I've always kept clinically active, and I've been fortunate. I've got a really good clinical group that allows me to do that. And up to really, honestly, I was even doing call as president CEO. I'd be a little bit grumpy by the end of the week, though, I'd have to confess. I would say that I did, to be honest, it wasn't such a big transition for me. I didn't notice that it was night and day. I think a lot of things that we do as clinicians are things that we do administratively. You have, group meetings, together with your division or your department. You have roles around things that you do as a clinician. And so it's not a far stretch to do, I would say, administrative. You just need to understand who's who in the system, how you can navigate, how you can connect, how to bring diverse voices to the table, and really how to make sure that everybody works as a team. In Alberta, we created a dyad model about, back in 2011, 12, because the physicians are responsible for 70% of healthcare costs. 70. So if you don't have physicians at the leadership table to be also accountable for budget, then how do you manage the system? And so we were very purposeful about investing in dyads at multiple levels. And physician leaders had joint accountability for budget. So they were as accountable as the non-physician dyad lead. And so that was a very important sort of parameter that we put in place, so that, you've got that clinician perspective into the operations of the health system. But I didn't necessarily find it a big transition.
Thank you very much to you. We'll have time for just another couple of questions here. So next one is, how did you stay motivated to keep going in the face of so many challenges during the COVID pandemic? And how were you able to keep the fire lit for yourself each day?
Oh my goodness. How can you not keep going during the COVID, right? Everybody in the organization, everybody was touched. Every Albertan, every Canadian, right? Every Manitoban. And you had to keep going. There was just no option. There was no option, put it that way. You could not stop. What kept me going? Obviously I had this awesome team that was, along with me on the journey. So, the people in the organization, I'm eternally grateful for. They're just incredible experts in their fields. And personally, my grandson, my little grandbaby, was born he was a COVID baby. And you know what? That's what you do, right? You go and hug your loved ones and put life in perspective. That's how you keep going.
Thank you. And last question to leave us with kind of a standing message. Maybe what kind of recommendations or advice do you have for those that are entering or continuing their healthcare leadership journey, and how they can apply that to move the healthcare system forward?
So first of all, I'm so glad to hear that. We need healthcare leaders, and regardless of whether you have a title or not, you can be a leader, right? And I think that's really important, is that you can be a leader no matter where you are. And I would just strongly encourage everyone to learn about leadership competencies and to keep developing yourself. Self-awareness is the number one fatal flaw, I would say, or lack thereof, for leaders. And so really important, leadership development is very important. And there are in really wonderful groups out there, right? You look at the Canadian Society of Physician Leaders, you know, they have annual meetings every year in May. And, you know, those are really good meetings where you get to, you know, learn about leadership and meet others that are sort of in similar paths and, you know, learn some tools and resources that can help you along the journey. But I just want to say, somebody now who's now back at university and not so much in the health system, I am always grateful to everyone who continues to work in the health system and wants to lead in the health system, because we need you more now than ever before. So thank you so much for your commitment.
Thank you so much, Dr. Yiu, and I will turn it over to Dr. Peter Nickerson for some closing statements for today.
Sure. Thanks very much, Victoria. I want to take the moment to thank Dr. Verna Yiu for her thought-provoking insights and sharing her experience. It's been a privilege to have her join us this evening, to see such thoughtful engagement from all of you. And I hope you're leaving today with some new perspectives and ideas that you can apply in your own work and communities. I know I'm going to have to re-listen to the talk again, Verna, just to get to all the pearls that were there, and think a little deeper on some of the concepts that you raised. And I certainly had a reading list coming out of the talk of things that I'm going to have to dive deeper and pull articles. And so I think you've stimulated us a lot and challenged us to really rise to the occasion and think deeply. And because I think what we are really dealing with is wicked problems. And these are not going to be solved with simple solutions. They're going to take some deep thought and some collective action and commitment and perseverance, I think, in the face of a political system that doesn't really look at the long-term solutions. They're really looking at the short-term. And so I do think that you've challenged us a lot in a long ways. So on behalf of the George and Fahey Center for Healthcare Innovation, thanks once again for joining us. We wish all of you a wonderful evening, and Verna, enjoy the quieter life of being provost.
Thanks very much, and thanks for the opportunity.
Take care.
Thank you. Bye-bye.
Bye-bye now.